Hi everyone, this is Dr. Solomon. This lecture will be on patent ductus arteriosus. The objectives for this presentation are to review fetal, transitional, and mature circulation on your own, and the links are on the next slide. Describe PDA or patent ductus arteriosus. Describe the signs and symptoms and complications of PDA. Develop a treatment plan with regimens and monitoring for a patient with PDA. Understand when a PDA should remain open with a prostaglandin infusion, and understand the risk of NSAID use in pregnancy. Before we begin, please take a look at these three resources. The first one is a reference from the pted.org, and this is a really great resource that looks at different cardiac defects and congenital heart defects and the surgeries to treat them. And then the second video and third video are fetal circulation and newborn circulation from the Khan Academy, and they're really helpful to explain what the PDA is, why it's so important, and kind of putting it all together with the different congenital heart defects that are on the first link. It will be helpful for you to understand just all of the circulation and how it all kind of fits together. So the PDA, or the ductus arteriosus, is a vessel that connects the aorta to the pulmonary artery for fetal circulation. And the function of this vessel is that the blood circulation will bypass the lungs in utero. And this is important because the lungs obviously aren't functioning as lungs in utero. So this vessel functions to oxygenate the blood and connect the two sides of the heart, the right side and the left side, using the PDA. And then the flow that this ductus arteriosus, the blood flow goes from high pressure from the aorta, or the left side of the heart, to low pressure through the pulmonary artery, which is the right side of the heart. So you can think about it in a way that the two sides, the left side and the right side of the heart, instead of being connected by the lungs and the pulmonary vasculature, it's really connected through the PDA, and it goes from high to low pressure from the aorta to the pulmonary artery. In utero, the patency is maintained by circulating prostaglandin. So what this means is that basically the ductus arteriosus stays open or patent by the circulating prostaglandin. And there's usually a lot of prostaglandin in the placenta itself. And then after birth, the PDA usually closes around 72 hours in term neonates. If they're born at full term, usually it closes in 3 days. If they're premature, it takes a little bit longer. It takes around 4 days to close. So in PDAs that do not close, these account for 10% of all congenital heart defects, and it is considered a congenital heart defect. And PDAs can be isolated, or they can be in conjunction with other congenital heart diseases. So the incidence, we see this more in premature infants more than term neonates, and then spontaneously closes more in premature infants compared to term neonates as well. So this is an image that shows the PDA and how it looks when it is patent. So again, just to reiterate what we said on the previous slide, the PDA is a vessel that connects the aorta to the pulmonary artery, and it's one of the essential shunts in fetal circulation, which is responsible for shunting deoxygenated blood from the right ventricle through the descending aorta, bypassing the fetal lungs, which does not oxygenate in utero. So some of the symptoms that we might see in a patient that has a PDA really depend on the size of the PDA, the age at presentation, and the relationship of pulmonary to systemic vascular resistance. So if the PDA is really large, we might hear a murmur. If the PDA is really small, we might not even have any symptoms at all, or any presenting symptoms in the patient. We might also see some signs of heart failure. So this can include sweating while feeding. This can include tachypnea. And because it takes so much effort for patients with PDA to perfuse their whole body, especially with a larger PDA, we might even see poor growth in infants and neonates. An additional thing that we can see with patients that have PDA is cyanosis, and that can be in related to the degree of perfusion that the patient may or may not have, again, depending on the size of the PDA. Some of the risk factors for PDA include prematurity. So patients that were born at, or neonates that are born before 28 weeks of gestation will have a 70 to 80% chance of having a PDA that doesn't close. And another risk for PDA is a lack of maternal antenatal steroids. So just to give a little bit of background on this, if a premature birth is imminent, mothers will, or practices will typically give a mom intramuscular corticosteroids to prevent neonatal diseases such as PDA, some lung diseases. So there's a whole bunch of indications for maternal antenatal steroids. And if they don't get that, that can increase the risk of PDA at birth. Additionally, respiratory distress syndrome, which is a common neonatal syndrome if they're born premature, this can also be another cause or risk factor for PDA. Some complications of PDA, large PDAs, or if it closes really late, that can lead to heart failure. And the reasons that this can happen is from pulmonary overcirculation or pulmonary hypertension. If the PDA is small, it may cause a risk for endocarditis, but it's usually benign. Ductal steal is where the ductus will steal blood flow from the vital organs. And this may present as poor renal perfusion, which can be shown as an elevated serum creatinine and acute kidney injury. We can also see increased pulmonary blood flow. We can also see hypotension, pulmonary hemorrhage, necrotizing enterocolitis or NEC, intraventricular hemorrhage, pulmonary edema, prolonged mechanical ventilation, or bronchopulmonary dysplasia. All right, so in order to diagnose PDA, typically it is initially diagnosed with auscultation using a stethoscope to listen to the heart murmur, and then it's confirmed with an echocardiogram. So I want you guys to pause right here and think, are PDAs more common in premature neonates or term neonates? All right, so this slide really just tries to illustrate the differences between closing the PDA or keeping the PDA open. So with closing the PDA, we would require closure in a heart defect, or if the patient has a murmur, if there is overcirculation. And like we said earlier on in the presentation, spontaneous closure usually occurs within 3 to 4 days after birth, especially if the infant is greater than 28 weeks gestation. And with these patients, they can be managed with supportive care, such as fluid restriction and respiratory support. And before closing the PDA, the team should really focus on reducing pulmonary congestion, reducing heart failure, and reducing pulmonary circulation. And this is typically done by restricting fluids and administering diuretics such as, there should be caution with loop diuretics because those can increase prostaglandin. And when you increase prostaglandin, that might make closure of the PDA a little bit more difficult. Now, as far as keeping the PDA open, this is important for patients that have a PDA-dependent lesion. And what I mean by lesion, I mean a heart defect. So since the PDA, the patent ductus arteriosus, connects the systemic circulation with the pulmonary circulation, and a heart defect where the heart defect where it's a cyanotic defect, meaning that there is deoxygenated blood circulating systemically, then we definitely need to keep the PDA open. I'm not going to get into too much detail with this in this lecture, but I just want you to understand that there is a situation in which the PDAs should remain open, and these are for cyanotic heart defects. Some examples of an overall summary of what we use to close the PDA: we use NSAIDs such as indomethacin and ibuprofen. We can also use acetaminophen. we can do surgical interventions, and we can also do nothing. So we're going to cover those in the next couple slides. So the first drug option for closing the PDA are NSAIDs. And NSAIDs reduce prostaglandin synthesis by inhibition of COX at the site of the prostaglandin H2 synthase enzyme complex. And this decreases circulating prostaglandin levels, and this constricts the PDA and eventually closes it. The first drug in the NSAID class that we'll use in this disease state is indomethacin. And I put the dosing here on the slide. And the dosing really does depend on postnatal age. And so you should check your drug info references before making a recommendation in practice, since the dosing does tend to change. But typically we'll give about 2 doses or so. For administration, we'll administer it over 20 to 30 minutes IV. And since this is an NSAID, we can see vasoconstriction. We can also see some urine output changes because it is a nephrotoxic agent. So we really should be checking urine output before each dose. Some side effects include renal dysfunction, necrotizing enterocolitis, GI bleeds, or spontaneous intestinal perforation. And for all 3 of these, the last 3 side effects, we really need to watch the patient if they have any abdominal distension, which could be a sign of these different side effects. It is about 70% efficacious, but that efficacy decreases with increasing age. The next drug that we can give is ibuprofen, and we can either give ibuprofen IV or PO. And again, the dosing is listed here on the slide. We'll typically give about 2 or 3 doses of ibuprofen. And this, again, the dosing does also depend on gestational age. The side effects are similar to indomethacin, but there's a lower incidence, and there is a decreased effect on mesenteric blood flow with ibuprofen. So this might be a preferred agent, just depending on the practice. Again, the efficacy is about 70%, and the efficacy decreases with increasing age. The next drug is acetaminophen. The use for acetaminophen is controversial, but the mechanism or the drug may be used and may be beneficial if there is a contraindication to NSAIDs. And acetaminophen works in this case by reducing prostaglandin synthesis by inhibition of the peroxidase site on the PGHS complex. And this can be given either IV or PO, and the dosing is listed there. And you'll notice that the dosing is a little bit different from the NSAID dosing on the previous slide. So this can be spread out over 2 to 7 days. There is a concern for hepatotoxicity and elevated LFT, so we really want to be cautious with this agent as well and monitor if we can. And there is limited efficacy and safety data for this indication, and this can be used as rescue therapy for patients who have failed NSAIDs, and the efficacy can range from 70 to 81%. So we'll stop here for a patient case. Baby QT is born at 27 weeks with hypoplastic left heart syndrome and a PDA. And just as a reminder, hypoplastic left heart syndrome is a cardiac defect in which only deoxygenated blood circulates throughout the body. What should the initial management be? A, wait for the PDA to close spontaneously. B, give an NSAID to close the PDA. Or C, administer prostaglandin infusion to keep the PDA open. The correct answer is C. Prostaglandin infusion must be used to keep the PDA open. Since this is a ductal dependent lesion, meaning that the patient is dependent on the PDA for survival, the PDA must stay open using a prostaglandin infusion. Waiting for the PDA to close spontaneously will decrease systemic perfusion and lead to death eventually, and also be closing the next case is baby TQ, born at 29 weeks with a PDA. What should initial management be? And for this case, we're assuming that nothing else is wrong with the patient, and we can just assume that the patient only has a PDA. So option A, wait for the PDA to close spontaneously. B, give an NSAID to close this PDA. Or C, administer prostaglandin infusion to keep the PDA open. So C is incorrect. We don't want to keep the PDA open in this case because the PDA is isolated. But between options A and B, since this patient is premature, we could argue either one of those answers. So we're going to talk about timing of treatment in the following slides. Okay, so for timing of treatment, the optimal timing is controversial. There are better outcomes if the PDA is treated early. However, the PDA might also spontaneously close. So it's difficult to tell if the PDA should be closed early on or just left alone and then closed later. However, if it's left open and given treatment, the efficacy decreases with increasing age, as we saw earlier on. Long-term benefits are really unclear, and late treatment, meaning treating after the patient's older than 14 days, the outcomes are unknown. So there still could be an indication for later delayed symptomatic treatment. An early fluid restriction may delay or negate the need for pharmacological treatment of the PDA, like we talked about earlier. So restricting the fluids or giving diuretics. And again, we don't really know what this is going to look like with sicker neonates. So it's kind of hard to say, but so different institutions will have different practices. As far as repeat courses go, response rate after the second course of ibuprofen or indomethacin is around 40%. The lowest rate of closure is in the most premature neonates, and it's unknown if several courses will increase the risk of side effects. Now for monitoring. For monitoring, we want to look at renal function using serum creatinine and urine output, platelets, especially if given NSAIDs. Given acetaminophen, we really want to look at LFTs. Again, if we're giving NSAIDs, we want to look at our GI and see if there's any signs and symptoms of GI side effects, such as bloody stools, abdominal distension, discolored abdomen, and there's also a risk of spontaneous intestinal perforation. Additionally, some get drug levels, but this is not routinely done. Another option, if drugs are not being used or if the patient fails drug therapy, we could do surgical interventions. And this is indicated if therapy has failed or if the patient is symptomatic. And this is also indicated for large PDAs, which have a harder time closing with drugs. So in these patients, the patient can get cathed and get their PDA ligated in a cath procedure. Can be embolized in a cath procedure, or it can be ligated in surgery. And there's low risk of sequelae, but it requires a specialized service to get this done. As far as prevention goes, there is dosing available for indomethacin to prevent PDAs. This can be indicated in newborns that are born that weigh less than or between 1,000 and 1,250 grams. There hasn't been shown to increase survival or to reduce long. But the bottom line for prevention in the dosing and giving indomethacin is that there is unnecessary exposure to indomethacin, and most PDAs close spontaneously, especially in this age range, in this weight as well. And ibuprofen and acetaminophen have not been studied for prophylaxis. We'll pause here for a patient case. A 35-year-old woman comes into your pharmacy. She's 39 weeks pregnant and would like to take ibuprofen for back pain and headaches. What would you recommend? So the answer to this question is that NSAIDs are contraindicated in pregnancy, especially in the third trimester, because NSAIDs can close the PDA, and especially if the baby is if they're still in utero, can cause premature closure of the PDA, which is definitely harmful while the patient still needs, or while the the fetus still needs the PDA to stay open to promote fetal circulation. So you definitely not recommend any NSAIDs during pregnancy, especially in the third trimester. So PDA is a common congenital heart defect that can be managed most commonly with NSAIDs or surgery, or can spontaneously close. They must be kept open with prostaglandin in patients that have cyanotic heart defects, and can lead to heart and other organ damage if not managed appropriately. Thank you for your time, and please let me know if you have any questions.